background is I'm a surgical care practitioner, and I'm a university lecturer running the courses for the surgical care practitioner. And a surgical care practitioner, probably most people won't know, is pre, peri and post-operative care for patients. So the scope of my practice is clinics, running independent ward rounds, independent operating and assisting in theatre. So basically the introduction to why I do, what we've got currently in the UK is we've got surgical care practitioners, and we've got surgical first assistants who are predominantly intraoperative, who surgically assist. Now, I decided to go to the United States because they have two roles over there. They've got the physician's assistant role, and they've got the nurse practitioner with the registered nurse first assistant qualification as well. And they've had those roles in practice for over 40 years, whereas we've only got 10 years experience in them. So I went to look at both roles in the education and clinical practice aspect, because I do both over here. And there's been a lot of resistance to these roles within the UK, particularly when we first started to establish the surgical care practitioner role. There was a lot of resistance from the Royal College of Surgeons because they felt that we would impinge on the training of the junior doctors. Fortunately, I was at a meeting 2 weeks ago at the Royal College of Surgeons, and there's been a massive shift and change, which I'll come to in a bit. So background to the project and why we're going to need these advanced roles. Essentially, we aren't going to be able to run our healthcare system in a matter of 6 years. It's going to be completely different, and the rationale for that is the enforcing of the European working time directives, the moving to 7-day working, the reduction of the junior doctors, and in particular in surgery they're moving the GP trainees out of surgery, the stricter immigration, and the financial implications for NHS. The amount of money, it's millions of pounds, are spent on locums within departments, particularly like an A&E department, constantly. So if you have a consistent workforce of surgical care practitioners or physician's assistants, you reduce that and you get continuity of care. Sorry, this is very busy. My aims before I went were to see the clinical development, were to improve when I returned the clinical development of surgical care practitioner roles nationally, to review how the roles in America were implemented, developed, evaluated and supported within clinical practice to ensure that there was quality and competency, to learn how they extend their knowledge to an advanced level, and to facilitate the development of surgical care practitioners, having reviewed the education and assessment over in America, and how they are able to make advanced clinical decision making in their new roles, which is ones that used to be carried out by medical practitioners. So when I went about organising my fellowship, I had an initial problem because no one understood me over the phone with my accent, so that was a bit of a barrier, and I struggled because people wouldn't email me back, or I was like constantly on the phones, people trying to, with the time difference, trying to get in touch with people. And as you know, as you mentioned, because you feel like you have this responsibility and you owe people and you want to achieve something, I didn't want to get over there and not have anything to do. So I was very lucky because my professor linked up with 2 hospitals over in America for me with his contacts, and I was supported here. And also, as you mentioned before, once I'd networked, they passed me on to other people and organised things for me when I got over there. And I contacted also the National Association of Physicians Assistants in America, and the Association of Operating Room Nurses too. One of my big debates when I was trying to organise my fellowship was how long to spend in each individual place, because I wanted to get enough breadth of experience but enough depth as well. So I sort of divided my fellowship with I originally started with just a few days in each place, and then my last 4 weeks I had 2 weeks at the Mayo Clinic and then two weeks in Houston at MD Anderson, and that was good because then it enabled me to get the depth of knowledge that I hadn't already achieved prior to that. And how much time in each area. They tended to put me a lot intraoperatively because that's my background. My background as a theatre sister. So I tried to get out of that a lot and managed to spend some time in outpatients, rounding, clinics and stuff. So that was very good, and with the educational facilitators. Something I didn't factor in a lot, obviously I was very clinical, so I was in the operating rooms and on the wards and had very much patient contact. I have never been vaccinated, had to prove so many blood tests. In fact, it was a constant joke in my workplace of how I could actually work for the NHS at the time. But that took a lot of extra time, and from hidden costs, costs, some of the hospitals over there tried to charge me money. So one of the hospitals wanted to charge me $3,600 to spend a week there that I hadn't factored in. Obviously I did manage to get around that, but at the time I was in a little bit of a panic as well. And the other thing that I didn't quite appreciate was the massive adapting to their different healthcare system. I caused a lot of confusion because I used to say medics for the doctors, but in America they call paramedics medics, so I caused confusion with that. I used to say like, oh, in theatre, and they'd be like, oh, did you used to be an actress? I was like, no, as a theatre nurse. And also they're like doctors, what they call the doctors and stuff is very different. So it did take me, I would say, a couple of weeks to try and get my head round fully around that. And I have kept in touch with everyone just to double check that I am using the right terms. So I had two hats on. I had my educational hat on and my clinical hat on. So from the educational lessons that I learned, I specifically liked that they were very much more structured. They had a standardised national curriculum that they stuck to. They were very structured in their clinical education. They have a national certification. So after they qualify, they all have to do a national standard exam. And then as physician's assistants, they have to redo that every 6 years. Now I did mention this at the Royal College of Surgeons 2 weeks ago, and I bristled while I waited for the response, and actually everyone really liked the idea of having a national standard surgical care practitioner exam, shockingly. The level of training, there was a bit of controversy between PAs and physicians assistants, and the MPs in America, and they're in competition over what level of training. So the MPs are just stepping it up to doctorate level at the moment, soon to be followed by the PAs by the way it's going. Their methods of assessment are very much more exam based. They've had very much more strict criteria for admission requirements. And the course structure for the PA I found particularly difficult to get my head around, because physicians assistants don't have a clinical background. They come in off the street essentially. Now, their very first year in the Cornell University, where I spent time with them, they do what they call a didactic year, and they didn't have any clinical practice for a whole year. I can't understand actually how you would teach someone the clinical principles of anything without having any clinical background. So fortunately, we're putting in for a bid for a physician's assistant course at our university, and I have just written the programme for that. And I've adapted the American model but incorporated clinical aspects because of that. The other thing was the medical model versus the nurses model. I suppose the big debate is, if you are training someone to do what has always been a historical medical role, do you train them with the medical model, or do you train them with a nursing model? And I can see the benefits to both. I think if you train someone with a nursing model and they're in a medical job, they have a different perspective, and that can always bring things. But if you train someone with a medical model, they have more of a relating to how it's people are communicated to in the medical model. So I'm still up for debate on that. And also with the aspects of generic, the physician's assistants were trained very much more generically, which is great for workforce planning, but I preferred in a way the nurse practitioners were being much more specialised, whereas the physician's assistants specialise once they're in clinical practice. From clinical aspects, the scope of practice again took me a while to get my head around the physician's assistants and the nurse practitioners, because both gave me the impression, depending on which one you were speaking to, that they had the more advanced scope of practice, that they were doing more. And actually, when I looked into it, they do exactly the same. So they both come out and do exactly the same scope of practice. What I really liked in America is they have protected titles. It's something we really struggle with here. I know a lot of surgical care practitioners, even my own region, who haven't done a set training, have only done in-house training, don't do the full scope of practice, and then call themselves surgical care practitioners. It's something that we're definitely pushing for at the Royal College of Surgeons to change. The other thing is that I love about my role in the English manner is the surgical care practitioners. It's pre, peri and post-operative. I often joke with my patients that I am actually their stalker, because I see them from clinic, pre-operatively, intraoperatively, follow them afterwards, see them for the cancer diagnosis, and then ring them with follow-up, and then see them post-operatively in clinic. In America, they very much divide it into inpatient and outpatient care. When I asked them what that was, they said it was for more of a work-life balance, which I can actually appreciate, but I much prefer how we do it in England. Obviously, the different ways of working reflected because of their healthcare system. And then they had this privilege thing, which I struggled to get my head around with as well. But the physician's assistant, because they're so generically trained, once they then go into clinical practice, they get specific privileges aligned with their physician, because they're actually not registered practitioners in America either. So their registration is almost linked on the physician's registration that they work for. And the documentation and clinical assessments are different as well. So the workforce planning over in America, they wouldn't be able to survive without their middle grades, and I don't think in the future we will be able to over here. It was very eye-opening seeing an independent healthcare system, and it's made me so grateful for the NHS. I would struggle to work in that system. The things that I saw were very upsetting at times. I think it's an amazing system if you have money, but if you don't, you really would struggle. The scope of practice was no more established than the UK. In fact, I have a more advanced scope of practice. They don't do independent operating, they don't do independent ward rounds. And so I learned a lot of new lessons, but I also confirmed theories that I had, and that was something I remember last time feeling quite reassured about from one of the speakers. So I remember saying, if you go over there and you just your theories are confirmed, you don't need to feel worried about that. You don't have to come back with loads of new stuff. So my recommendations from it are: protected titles linked in with scope of practice and education, nationally accredited and standardised courses with standardised entry requirements, with no in-house training, because I don't agree with it for lack of quality control, incorporation of basic surgical skills into the surgical first assistant role. Physicians' assistants need to be registered in the UK and have prescribing rights, or they'll be significantly restricted in compared to how they work in the US. National certification, a separate section on the register to identify advanced practice and an advanced code of conduct. So since I've got back, I've made some changes in my immediate clinical environment, done some presentations at the university. I've adapted some of how I run the surgical care practitioner master's programme already to incorporate some of the American techniques. And I've also, as I mentioned before, I've co-written the physician's assistant programme to hopefully, if we get the bid for that. I've been at a few meetings with the Royal College of Surgeons and been in touch with the Royal College of Nursing and the Association of Operative Practice, approached to write 3 articles, and one of which is overseas, and I am in contact. I didn't realise relationships wise, I feel like I've not only got colleagues, but I've got friends over in the US, and we're in contact weekly on email or Skype or over the phone, and they've offered to help me with, they've been so generous with their knowledge and sent me so much information, and I just really appreciate it. So, thank you.